Good afternoon. I have the pleasure to continue the series of update in lupus nephritis, and this is the last presentation regarding this issue. I'm going to highlight the renal replacement therapy and be followed by discussion. Before you proceed in listening to this tape, please look at the diagnosis and treatment sectors that are already uploaded a few days ago. Regarding the end-stage kidney disease in lupus nephritis, if the patient has lupus nephritis with high baseline creatinine, lower baseline estimated GFR, high degree of proteinuria, higher cellular cast, hematuria, pyuria, high blood pressure, and thrombotic microangiopathy, all these are criteria that increase likelihood of development of end-stage kidney disease in lupus nephritis patients. One of important point, because all nephrologists are aware that dialysis dampen lupus activity and leads to burning out, as burning out hypothesis stated, but sometimes patients on dialysis develop lupus flare. And these are the study that showed the flare in lupus patients. And the commonest presentation of flare in this series was hematological manifestations, followed by mucocutaneous, articular, serositis, myopericarditis, fever, diffuse alveolar hemorrhage, and cutaneous vasculitis. The most important key message from this article is systemic lupus erythematosus flares are not infrequent after patients start renal replacement therapy. So we should think of that, the extrarenal activities on dialysis, because these patients are already dialyzed, either hemodialysis or peritoneal dialysis. The most common type of activity during systemic lupus erythematosus flares was hematological. Low complement for anticardiolipin IgM and younger age are associated with systemic lupus erythematosus flares in end-stage renal disease. So these are the risk factors for flare. Regarding dialysis outcome, what is your expectation? Is the outcome of lupus patients on dialysis the same like non-lupus? The answer is no. Lupus nephritis adversely affects patient survival. This is one of the data registry from Australia and New Zealand for 425 dialysis patients with lupus nephritis in this period from 1998 to 2012, found a 5-year patient survival rate of 69% survival. That was worse than for matched dialysis control without lupus. So lupus is bad news in dialysis. Regarding the impact of serology in deciding the timing of transplantation, this is a very nice study because we are occupied by serology all the times. So the utility of lupus serology in predicting outcomes of renal transplantation in lupus patients is the focus of this study. Systematic review. This is a systematic review of literature and analysis of the Toronto lupus cohort. The main result of this analysis is merely positive serology has no effect on the transplant outcome. So we shouldn't depend only on positive serology for deciding the time of transplantation. If I have a patient with no extrarenal activities, we can proceed for transplantation even if the serology is positive for antinuclear antibody and complement. The most important serology that should be respected and to be known is the positivity for antiphospholipid syndrome. And we should discriminate between antiphospholipid serology positivity and the syndrome. The difference is the syndrome has positive serology plus the presence of thrombosis, either frequent occlusion of fistulae, recurrent abortion, or the presence of thrombosis at any place. If the patient has positive serology for antiphospholipid only, the patient, we advise that the patient to be maintained on antiplatelet. But if positive serology is associated with thrombophilia and thrombosis, these patients need anticoagulation. Regarding the long-term outcomes of end-stage kidney disease, this study shows dialysis and transplantation. Patient survival is affected by lupus in dialysis and in the same in transplantation, but graft survival is not affected by lupus. So graft survival in lupus patients is like other etiologies, but patient survival is still affected in transplantation. But this means, that doesn't mean to discriminate these patients. The best renal replacement therapy for lupus nephritis who present with end-stage kidney disease is renal transplantation. And this study is very interesting because it includes 32,000 patients. And the etiology of these patients for end-stage kidney disease is glomerulonephritis, FSGS in 13,000, IgA nephropathy in 7,000, membranous in 2,000, MPGN approximate 2,000, and lupus nephritis in 5.8 thousand patients, or vasculitis in 1.3 thousand patients. And this study shows that the presence of glomerulonephritis is not good, and the survival is affected by FSGS, as you see. IgA nephropathy doesn't affect survival, because as you see, this is the result of the analysis, no difference. So IgA nephropathy is comparable to other non-glomerular etiology. FSGS affects survival, membranous affects survival, MPGN, lupus nephritis, all these are associated with worsened survival in comparison to non-glomerular etiology. So all these data should be put in consideration. If we look at all-cause graft failure, lupus nephritis is there still. So lupus nephritis is a very important issue that may affect the outcome. One of the important ones is recurrence. Recurrence in lupus is not common like FSGS. It is less common and usually treated with the conventional treatment because the patients are already maintained on immunosuppressive drug, except in severe situation we may intensify immunosuppressive drugs. This is a very nice study, although it included 12 cases for recurrence. Here the recurrence is either clinical, or here the recurrence is clinical in 3 cases and subclinical 2 cases, 4 cases. So clinical recurrence is evidenced in 4 cases and subclinical in 2 cases. Subclinical means it is proven in biopsy, just in protocol biopsy. I don't recommend protocol biopsy to diagnose recurrence so long as the patient is asymptomatic. So surveillance biopsy, I think it is not justified in the absence of urinary abnormalities or allograft function. But if there is urinary abnormality or graft dysfunction, biopsy is needed. And if the clinical activity is there, the graft may be affected by graft loss. One of the important questions, if we have the native pathology, class 3 or 4, do we expect that we will find all the patients who will develop recurrence in the same like class 3 or 4? The answer is no, because transplanted patients are maintained on immunosuppressive drug. So as you see here, the majority of patients are class 2 or membranous, and less here 10 patients are within peripheral lupus nephritis, here just 3 patients after transplantation. So it's not necessarily to have the same class in recurrence, and we expect recurrence is lower in its class. Pregnancy is still risky business, and we should stratify the risk for patients, for ladies after transplantation, for lupus patients who are already transplanted, because lupus increase the pregnancy increase lupus failure even after transplantation. Malignancy. The oldest dogma is lupus nephritis is associated with dysregulated B cell, and this may increase risk of lymphoma. Along with this, a larger series that included 100 39,000 non-lupus, 4,000 lupus. The answer is there was no significant difference in the all cancer except melanoma is little bit higher in lupus patients and lung cancer higher in non-lupus patients. So the risk of cancer is not so much in lupus patients. To reach the guidelines that is demonstrated in this article, renal replacement therapy, we have transplantation and dialysis. Transplantation is preferred if lupus activity is absent or low for 3 to 6 months or 6 to 12 months according to difference in grades in the guidelines. But the most important is absence of extrarenal activity plus no comorbidities, and the patients are already withdrawn from immune suppressive drugs or maintained on very low dose of immune suppressive drugs. We can proceed for transplantation because renal transplantation is the best management for end-stage kidney disease lupus patients. Dialysis there is an increase in risk of infection in patients maintained on immune suppression, still maintained on immune suppression while they are on dialysis. Increased risk of vascular access thrombosis in patients with antiphospholipid syndrome. So again, we look at antiphospholipid serology. If lupus is inactive for peritoneal dialysis, if there is no activity, peritoneal dialysis may be, and if the patient prefer peritoneal dialysis, we can proceed for peritoneal dialysis. But if lupus active, the hemodialysis is better. Regarding transplantation, determine antiphospholipid positivity and associated risk of vascular events before proceeding for transplantation, as I mentioned in the beginning. So these are the most important points to be considered when we decide the modality of renal replacement therapy. In less than 5 minutes, I'll discuss some important points. Regarding plasmapheresis, I received a question from Dr. Tariq Tantawi mentioned that plasmapheresis is not so clear in the treatment presentation sector because he mentioned that if there is lupus cerebritis, this is better to start plasmapheresis. And my answer is plasmapheresis has a role, although it is not so clear in lupus nephritis, because in the study I mentioned in the treatment sector, it reduced the immune suppression and shortened the time for remission, because at the end of the day, plasmapheresis remove antibodies. But this is a very important point. If you have thrombotic thrombocytopenic purpura presentation in a patient with lupus, there are 2 types of renal vascular lesions in lupus nephritis. One of them is responsive to plasmapheresis and the other is not. Look at this slide. There are thrombosis here and there, but the vessel, the immunoglobulins are deposited and staining the wall and empty in the lumen. And here, this is the special phosphotongestic acid hematoxylin is positive. So whenever you find positive phosphotongestic acid hematoxylin and absence of immune fluorescence inside the lumen of the vessel, and this means that this is thrombocytopenic purpura. But if the lesion is like this, negative for phosphotongestic acid, and the presence of IgG and the complement within the lumen of the vessel, this means that this is lupus vasculopathy, and this patient this is a clue for response to plasmapheresis. Regarding refractory lupus, it is important to know the treatment and to make shift to other treatment like cyclophosphamide to MMF or vice versa. And we may think of IVIG, plasma exchange, pulse steroid, and alternative treatment like rituximab, as I mentioned before. Regarding the need of mesenchymal stem cell, is there a rule for mesenchymal stem cell therapy for kidney disease in general and the lupus nephritis. This is one of the important to review and giving clinical evidence regarding lupus nephritis. These are the preliminary studies in phase 1 and phase 2. 3 of them used umbilical source of mesenchymal stem cell, and 2 of them used the bone marrow derived mesenchymal stem cell. The main mechanism of mesenchymal stem cell is immunomodulatory. It may help, but we are still waiting larger evidence-based recommendation. I think this is the one of the important point. Leptin, is there any role of leptin? And if there is any link between leptin and SLE, this is one of the research highlights. Leptin promoted effector T cell responses and presentation of self-antigens to T cell and inhibited Treg cell. This means leptin is bad and increase lupus, and this may open in the horizon for treatment against leptin, anti-leptin drugs to target lupus erythematosus. If you have any question regarding lupus nephritis, please don't hesitate to send it to my email, and you will find a reply within 5 days. Thank you very much for listening, and I think after 1 year we will meet again to review the evidence, the new evidence for new management or new risk factors or new armamentarium for the management of lupus nephritis. Goodbye, and thank you very much.